नमस्ते आदरणीय व्यक्तित्वहरू। आज हामी नेसनल न्यूनेटल हेल्थ स्ट्राटेजीलाई कन्टिन्यू गर्दैछौँ र हिजो हामी बिहेभियर चेन्ज कम्युनिकेसन बारेमा डिस्कसन गर्दै थियौँ। यसैलाई नै मैले नदोहोऱ्याइकन अगाडि बढ्न चाहन्छु। To extend the extended testing of birth preparedness package जीवन सुरक्षा to improve the decision making and health seeking behavior among community members, strengthening the existing school and community reproductive health education and education on care of the normal newborn, example breastfeeding to be included in the nutrition curriculum for school children at least 9 and 10, the introduction and evaluation of BCC activities to promote kangaroo mother care or other culturally suitable practices for low birth weight babies, advocacy activities such as the establishment of National Newborn Week of activities, strengthening coordination with other subcommittees, example reproductive health coordination committee, safe motherhood subcommittee, child health subcommittee to promote care of pregnant women and newborn, social mobilization of women organization, NGO and local organization to improve maternal and neonatal health, promote BCC activity through TBA, FCSB, mother groups and other community group with the involvement of husband and family such as parent-in-law, focusing on the prevention of harmful traditional practices, especially those likely to cause or aggravate hypothermia, lead to infection, lead to suboptimal breastfeeding, lead to delays in seeking care for the sick newborn or inappropriate referral. The recognition of neonatal dangers and feeding difficulties or not is sucking, breathing problem, convulsion, fit, fever, hypothermia, severe jaundice, continuous vomiting, severe infection of umbilicus, eyes, skin and other sign of infection and appropriate action and appropriate referral. Reinforcement of BCC messages targeting danger sign during pregnancy, delivery and the postnatal period. Promote BCC messages to community influential to support health provider and family to create an enabling environment for improved care of pregnant women and newborn. Strengthening health service delivery. The National Neonatal Health Strategy promote the implementation of a specific level of neonatal health care intervention to improve the health service delivery, which can be seen in Annex 1 and 8. The improved coverage of skill attendance at delivery. Improving competency of all cards of health worker in essential newborn care, improving BCC knowledge and skill to promote ANC messages in the community, developing standard guideline along with review and adaptation of in-service training manual and curriculum for all cardio of health worker to include ANC. The development of pre-service training in appropriate ENC for all health workers, including doctor, nurses, ANM, FC, MCSW, auxiliary staff involved in the newborn care. Preparing non-formal caregiver, friend, relatives, FCSB, TB, and other unskilled health workers at delivery to assist in providing appropriate care for neonate. Whilst the National Neonatal Health Strategy see the presence of 2 attenders at all birth, 1 to attend the mother and 1 to the neonate is idle. Only 13% of delivery currently receive skill attendance. The National Neonatal Health Strategy recognizes that this must be a long-term objective. Hence, training of skill attenders should be emphasized how the assistance of non-formal caregiver at delivery can be best engaged to provide appropriate care for neonate. Postnatal visit within 24 hours to 48 hours, again within 6 days and a third day 86 week by skill trained attendant at home or at a health facility. The piloting of carefully supervised studies of the use of antibiotic, which could include both different drug and mode of delivery by community level health worker to treat neonatal infection, followed by by expansion of successful intervention, linking up with integrated management of childhood illness to include the total neonatal period as well. The introduction, promotion, and evaluation of kangaroo mother care or other culturally appropriate practice for low birth weight babies at various levels of care. Support and coordinate is to strengthen the National Maternal and Neonatal Tetanus Elimination Program, National Nutrition and other related program, establishing a well-functioning referral system with appropriate transfer for sick newborn, piloting of a scheme to link skill attainment at birth and birth registration, the notification of stillbirth and neonatal death by all community health workers. Strengthening program management. The National Neonatal Health Strategy promote the review of neonatal content of existing curricula, pre and in service and protocol, in particular the one developed for safe motherhood IMCI for all level of care provider, the deployment of skill sharing, clinical and audit with higher level of specialist and staff having a fixed short-term rotation in peripheral institution, to strengthen the lower level of facilities for newborn care, to train and supervise staff and establish a strong referral system, to develop the deployment of indicator CNX9 for the recommended list of indicator and the system to monitor and evaluate neonatal health status at all level integrated into the present HMIS, assure quality of care, equipment, supplies and drug for newborn care at all level by regular monitoring using standard checklist, continuing medical education for updating to be arranged at regular interval for medical and paramedical personnel, promote newborn care health practices in governmental, non-governmental and private through coordination and collaboration at a different level. The deployment of indicator CNX9 for the recommended list of indicator and the system to monitor and evaluate neonatal health status at all level integrate into the present HMIS. Research. A national neonatal health strategy promote community-based operation research to improve neonatal care. Example: home-based management of low birth weight neonate, community-based management of neonatal infection, care-seeking behavior of family for their sick newborn, and impediment to early care-seeking, etc. The evaluation of quality of maternal and neonatal care offered by all level of health worker, along with a reassessment and strengthening of their role as skilled attenders in the light of the result. The promotion of verbal autopsy of perinatal death in the community and perinatal death audit or review in peripheral hospitals. Cross-cutting issues. The National Neonatal Health Strategy promote the following cross-cutting issues which applies for every strategic intervention: multi-sectoral involvement, working in partnership, participatory from primary to higher level of stakeholders including the community, local authorities and leader, civil society, professional organization, private, non-governmental and governmental organization. Participation from primary to higher level of stakeholders including the community, local authorities and leader, civil society, professional organization, private, non-governmental and governmental. References, you can see the references here. I have skipped the references. Definitions. Here are some definitions used in the National Neonatal Health Strategy. Essential neonatal care, ENC. ENC encompasses a key aspect of the management of neonate, whether in the community or a health facility, including warmth, cleanliness, breastfeeding, cord and eye care, and immunization. Basic is essential obstructive care, BOC. BOC encompasses the management of normal and complicated pregnancy, delivery and the postpartum period for mothers and newborn. Service at health center level include at least the following: administration of perinatal antibiotic, administration of parental oxytocin drug, administration of parental anticonvulsant, manual removal of placenta, evacuation of product of conception, MBA, assistant delivery by vacuum or forceps. Community health worker, CSW, a worker at community level who has received training in aspect of prevention and simple curative care. This individual could be government staff or a volunteer. The document referred to MCSW, VSW, FCSB, TBA as a CSWs. Comprehensive essential obstructive care, COC. BOC plus the following additional service: anesthesia, blood transfusion, surgical obstructive intervention including cesarean delivery and repair of high vaginal or cervical tears. Fetal death. Baby born a date after 22 weeks of gestation or birth weight between 500 to 1000 grams. Late fetal death. Baby born date after 28 weeks of gestation or birth weight over 1000 grams. Infant, a child under the age of 1 year. Infant mortality rate, the number of infant death per 1000 live birth. Intrauterine growth restriction. Intrauterine growth restriction is a process of growth restriction during pregnancy that results in the birth of the baby whose weight less than expected for gestation. Kangaroo mother care, an approach using the care of both preterm and low birth weight babies based on continuous skin to skin contact with the mother, designed to encourage breastfeeding and provide continuous warmth. Low birth weight babies, birth weight lower than 2500 grams, immediate moderate low birth weight of 1500 to 2499 grams, very low birth weight less than 1500 grams, neonate or newborn, a live born infant from birth to before reaching 28 complete days of age. Neonatal mortality rate, the number of live born babies who die in the first 28 days after birth per 1000 live birth. Non-formal caregiver are those who possess the knowledge of a defined set of cognitive and practical skills that enable individuals to provide and assist in appropriate care of mothers and newborns. They could be friends, relatives, family member, volunteer, and other individuals. Perinatal mortality rate. Perinatal mortality rate, the number of stillbirth weighing 1000 grams or 28 complete weeks of gestation and death in the first 7 days of life per 1000 live birth. Extended perinatal mortality rate, the number of stillbirth weighing 500 grams or 22 completed week of gestation and death in the first 7 days of life per 1000 live birth. We can see here 500 gram, 22 and 1000 gram and 20. These are the difference in perinatal mortality rate and extended perinatal mortality rate. Preterm premature birth, live birth before 37 weeks gestation. Skill attendant refer to the process by which a pregnant woman is provided with adequate care during labor, birth, and the postpartum and immediate newborn periods. This requires the attendant to have a necessary skill, be supported by an enabling environment at the domiciliary PSC or first referral level, where there must be adequate supplies, equipment, and infrastructure, as well as an efficient and effective system of communication and referral transport. Interagency Group of Safe Motherhood, November 2000. Skill attendant. A skill attendant is a professional caregiver who possesses the knowledge and a defined set of cognitive and practical skills that enable the individual to provide safe and effective health care during childbirth to women and their newborn in the home, health center, and hospital setting. WHO 2000. Skill attendant include the health personnel with a midwifery and life-saving skill. In the context of Nepal, the maternal and child health worker, auxiliary nurse, midwife, nurse, and doctor are considered skill attendant. Small for gestational age. SC refer to the baby whose weight is less than the 10th percentile for gestation and gender. Stillbirth, the death of fetus weighing less than 500 grams or when baby weight is on a viable level after 22 complete weeks of gestation or with a crown heel length of 25 cm or more before the complete explosion or extraction from its mother. Annex, we can see various annex here. Annex 1, neonatal healthcare intervention by level. Level B, Zonal Hospital. Level 3, Central Specialist Hospital and Teaching Hospital. Strategic aim, type of neonatal care proposed. Annex 2, evidence-based response to neonatal health status. The wide range of internationally accepted evidence-based interventions that are known to improve neonatal health. Some of these are listed below. This is not an exhaustive list, but highlights a body of key evidence that is relevant to Nepal and the foundation of strategic direction described in this document. The evidence base for intervention during pregnancy include the prevention, detection and treatment of various endemic diseases that present serious risks to mother, fetus and neonates such as syphilis and other STIs, malaria, urinary tract infection and tetanus. The detection and treatment of serious complications of pregnancy such as preeclampsia, eclampsia and vaginal bleeding. BCC can be effective in helping mothers stop smoking in pregnancy and lead to a reduction in the incidence of low birth weight and preterm birth. Iron folate supplementation can reduce the incidence of maternal anemia. Detection and appropriate referral of multiple pregnancy and malpresentation reduces neonatal risk. A birth plan can promote communication between woman and her caregivers. The evidence base for intervention during labor include childbirth is safer for mother and neonate if a skilled attendant is present at delivery. Promotion of clean delivery can reduce maternal and neonatal death. Antibiotic prophylaxis for pre-labor rupture of membrane for more than 18 hours, whether term or preterm, improve maternal and neonatal outcome. In the hand of a competent health worker, the partogram can reliably detect prolonged labor. The evidence base for intervention for the care of newborn include normal neonatal care, skillful skin contact immediately after birth, maintain the neonate temperature, promote early breastfeeding and help to prevent neonatal infection. Skillful skin contact can both prevent and reserve hypothermia. Covering the neonate head can significantly reduce heat loss. Newborn that share their mother breast will breastfeed more often and for longer period. Early bathing of the newborn can lead to the hypothermia. Nothing should be put on the cord stump. The application of substances and unsuitable dressing can lead to tetanus and septicemia. Low birth weight. Kangaroo mother care is safe for well stable low birth weight neonate, but there is need for further pilot testing and evaluation in different settings. Infection rates are higher in low birth weight infant when no colostrum is given. Breastfeeding. Mothers who breastfeed early are more likely to breastfeed longer. Breastfeeding decreases the risk of neonatal sepsis. Breastfeeding aids cognitive development. In resource-poor countries, artificial feeding is associated with a significantly higher infant morbidity and mortality. Support from health workers and lay people can be effective in promoting exclusive breastfeeding. The practice of giving free formula gift pack to new mother result in a shorter duration of breastfeeding. Community breastfeeding promotion program can lead to dramatic increase in exclusive breastfeeding. Breastfeeding promotion is probably the most cost-effective intervention to reduce diarrheal disease. Colostrum contain antibodies which afford local gastrointestinal immunity against organism entering the body via this route. Sepsis. Home-based neonatal care in rural India involving village health worker, whose role was extended to include antibiotic prescribing and TBA lead to remarkable and cost-effective reduction in neonatal mortality rate. In rural Nepal, the role of FCSB, MCSW, BSWs have been successfully extended to effectively recognize and treat pneumonia in older infants. Birth asphyxia. Almost 80% newborn that require resuscitation can be treated with no more than bag and mask ventilation, and most can be revived as effectively with air as with oxygen. Annex 3, essential care for newborn health. Care for future mother, improve health and status of women, improve the nutrition of girl, discourage early marriage and childbearing, promote safer sexual practices, provide opportunity for female education, care during pregnancy, improve the nutrition of pregnant women, immunize against tetanus, screen and treat infection, especially syphilis and malaria, improve communication and counseling, birth preparedness, awareness of danger sign and immediate and exclusive breastfeeding, special attention, monitor and treat pregnancy complications such as anemia, preeclampsia and bleeding, promote voluntary counseling and testing for HIV, reduce the risk of mother to child transmission, MTCT, of the HIV care at the time of birth, ensure skill care at delivery, provide for clean delivery, clean hand, clean delivery surface, clean cord cutting, timing and tying and stomach care, and clean clothes. Keep the newborn warm, dry and warm baby immediately, including head cover or put to skin with mother and cover. Immediate exclusive breastfeeding at least within 1 hour. Give prophylactic eye care is appropriate. Special attention: recognize danger sign in both mother and baby and avoid delay in seeking care and referral. Recognize and resuscitate asphyxiated babies immediately. Pay special attention to warmth, feeding and hygiene practice for preterm and low birth weight babies. Care after birth. Ensure early postnatal contact. Promote continued exclusive breastfeeding. Maintain hygiene to prevent infection. Ensure clean cord care and counseling mother and general hygiene practice such as hand washing. Provide immunization such as BCG, OPV and hepatitis B vaccine as appropriate. Special attention: recognize danger sign in mother and newborn, particularly of infection, and avoid delay in seeking care and referral. Support HIV positive mothers to make appropriate sustainable choices about feeding. Continue to pay special attention to warmth, feeding and hygiene practices for low birth weight babies. Source: A State of Old Newborn, a report from Saving Newborn Lives. Annex 4: Causes of newborn death and proven intervention to prevent it. Causes of newborn death: infection, sepsis, meningitis, pneumonia, neonatal tetanus, congenital syphilis. Proven intervention: maternal tetanus toxoid immunization, syphilis screening and treatment, household use of the clean delivery practices, community level prevention of hypothermia, early and exclusive breastfeeding, community level identification and prompt treatment of infection, birth asphyxia, skill attainment at birth, effective management of maternal obstructive complication, preterm and low birth weight, malaria treatment in endemic area, community level prevention of hypothermia, early and exclusive breastfeeding, community level identification and prompt treatment of infection. Annex 5: Trend of NMR and IMR. Annex 6: How complication affect mother and baby. Severe anemia, problem complication in mother, more serious effect on mother cell, more serious effect on fetus, newborn baby. Severe anemia, cardiac failure, low birth weight, birth asphyxia, stillbirth, hemorrhage, shock, cardiac failure, infection, birth asphyxia, stillbirth, hypertensive disorder of pregnancy, eclampsia, cerebrovascular accident, low birth weight, birth asphyxia and stillbirth, obstructive labor, fistulae, uterine rupture, prolapse, amniotitis, sepsis, stillbirth, birth asphyxia, sepsis, birth trauma, handicap, infection during pregnancy, sexually transmitted disease. Promote premature onset of labor, ectopic pregnancy, pelvic inflammatory disease, infertility, premature delivery, neonatal eye infection, blindness, pneumonia, stillbirth, congenital syphilis, unclean delivery, infection, maternal tetanus, neonatal tetanus, sepsis, premature rupture of membrane and peripheral sepsis, septicemia, shock, neonatal sepsis, hepatitis, postpartum hemorrhage, liver failure, hepatitis, malaria, severe anemia, cerebral thrombosis, premature intrauterine growth retardation, unwanted pregnancy, unsafe abortion, infection, pelvic inflammatory diseases, hemorrhage, infertility, increased risk of morbidity, mortality, child abuse, neglected abandonment, smoking, abortion, premature labor, IUGR, prematurity, alcohol intake, alcoholism, IUGR, fetal alcoholic syndrome, mother baby package, implementing safe motherhood in countries, WHO. Annex 7: Selected demographic information on neonatal health, DHS 2011. You can see here न्यू डाटा पुरानो भएको कारणले मैले यसलाई चाहिँ सरल देखाएर यहाँलाई चाहिँ स्किप गरिरहेको छु। हाम्रो नयाँ लेटेस्ट डाटाहरू पनि हामीसँग आइसकेको छ। न्यूनेटल मोर्टालिटी बाई सोसियो इकोनोमिक एन्ड डेमोग्राफिक क्यारेक्टरिस्टिक, अर्बानमा चाहिँ 36.6 छ नि, रुरलमा 48% छ भन्ने कुरा देखाएको छ। माउन्टेनमा चाहिँ 64.9 छ, हिल र तराईमा चाहिँ 41 र 49, 41.9 र 49.7 छ। रिजनल हिसाबले चाहिँ फार वेस्टमा धेरै देखाएको छ त्यति बेला। family communities ties families and communities awareness of normal newborn care danger sign भनेर चाहिँ यहाँ दिएको छ। यो चाहिँ हाम्रो एनेक्समा रहेको छ, एनेक्स 8 मा रहेको छ। यहाँले हेर्न सक्नुहुनेछ एकदमै रमिलो छ, एकदमै देख्न पनि गाह्रो छ। मैले त्यसैले यसलाई स्किप गरिरहेको छु। Annex 9 मा some indicator of neonatal health and health services के छ त indicator community or facility is appropriate, source frequency will vary with program need, reduction in neonatal mortality rate, percentage of mother whose birth was attended by the skilled provider, percentage of mother whose birth was attended by the trained provider, percentage of mother who have received the 2 TT during last pregnancy, percentage of mother who breastfeed within 1 hour, percentage of mother who exclusively breastfeed at 3 days and 1 month, percentage of mother who receive ANC into 4, percentage of mother receiving ANC who were counseled in at least 2 of delivery preparation, breastfeeding and danger sign, percentage of home delivery in which cord was cut with a clean new instrument or a clean delivery kit was used and no substance was applied to the cord, percentage of women who deliver at home who receive a postnatal visit within 48 hours, percentage of women who receive postnatal care who are counseled in at least 2 of warmth, breastfeeding and danger sign, percentage of women who know at least 2 danger sign in each of pregnancy, delivery, postpartum and neonate, community nurse cause specific neonatal mortality rate। अब यहाँ मोस्ट अफ दी चाहिँ स्याम्पल सर्वे अबबाट गरिन्छ भनेपछि यो कम्युनिटी कज स्पेसिफिक न्यूनेटल मोर्टालिटी रेट चाहिँ बर्बल अटोप्सी सर्वेबाट लिइन्छ र भेरिएबल भनेको छ यसलाई चाहिँ फ्रिक्वेन्सी हेर्दाखेरि indicator community or facility is appropriate, percentage of FCG who has been successfully trained to conduct BCC activity with mothers group, percentage of women in mothers group who have engaged in BCC activity that can identify at least 2 of warmth, breastfeeding and danger sign, no district in BPP is promoted भनेर यसरी चाहिँ विभिन्न खालका percentage of यो indicator दिइरहेछ फेरि पनि indicator छ percentage of facility design is baby friendly, percentage of facility successfully reaccredited is baby friendly, no innovative pilot scheme to explore extension of role of junior health worker approved भनेर राखिएको छ र एनेक्स 10 मा रहेको छ author of the national neonatal strategy position पेपरमा को हुनुहुन्छ त भन्ने कुरा चाहिँ normal newborn care, breastfeeding and micronutrient, hypothermia, low birth weight, jaundice, asphyxia, इन्फेक्सन डेन्जर साइनमा को अथर हुनुहुन्छ भनेर यहाँनिर रहेको छ र एनेक्स 6 मा मेम्बर अफ द नेशनल न्यूनेटल स्ट्राटेजिक वर्किङ ग्रुप भनेर चाहिँ रहेको छ नामहरु। थ्यांक यू सो मच। मैले नचाहिने कुराहरु चाहिँ स्किप गरेको छु तर पनि यो नेशनल न्यूनेटल हेल्थ स्ट्राटेजी 2004 भए तापनि चाहिँ एकदमै गाइडिङ डकुमेन्टको रूपमा चाहिँ रहेको छ र हामीले जहिले पनि चाइल्ड हेल्थको कुरा गर्दाखेरि चाहिँ नेशनल न्यूनेटल हेल्थ स्ट्राटेजीलाई चाहिँ जहाँ पनि इन्क्लुड गरेको कारणले गर्दा मैले यो यहाँ समक्ष भाषण गरेको छु। यहाँहरुको केही कमेन्टहरु राय सुझावहरु छ भने कृपया कमेन्ट गरिदिनु होला। थ्यांक यू सो मच। सी यू अगेन।